welcome to endometriosis webinar today. My name is Hye-In Park. I'm a minimally invasive gynecologic surgeon in NYU Langone, Long Island. I'm so happy to have this webinar today regarding endometriosis and hormone. We have a wonderful panel, Dr. Margaret Nachtigall. She is a well-known reproductive endocrinologist and also expert of hormonal treatment. Welcome.
Thank you.
So today we are focusing on hormonal treatment of endometriosis and also the side effect and what's the alternative option for hormonal treatment of endometriosis. So endometriosis is the disease where the viable estrogen sensitive endometrial gland outside of uterus, usually it occurred in 10% of reproductive age group and 30% of infertility patient and 70% of chronic pelvic patient. So surgery is still gold standard of the diagnostic treatment of endometriosis. However, we must balance to diagnose when we see this endometriosis patient regarding surgical morbidity, also maintain the ovarian reserve in somebody who wants to have a baby. So the goal of medical treatment is to induce hypoestrogenic condition by suppressing the ovulation. There are different forms of medical treatment, including combined estrogen and progesterone-only treatment and progesterone IUD, and also alternatively GnRH agonist and antagonist, and lastly aromatase inhibitor. So now it's time to give it to Dr. Margaret Nachtigall regarding hormonal treatment option and this, like details each options. Dr. Nachtigall?
Sure. Hi. Welcome. So we really want to talk about today the different hormonal options and what the side effects and what you can do to alleviate some of the side effects. So we'll start with first using a combined either oral or vaginal or transdermal option that contains both estrogen and progesterone. And this probably has the least side effects of all because the birth control pills or patches or rings are able to suppress a person's own ovulation and therefore bring their own estrogen and progesterone down to very, very low, and then add back as low a pill as possible. And in most cases, this is very well tolerated. The only downside is that there are some people who the birth control pill alone is not enough to treat their endometriosis. However, if they are, this is usually a really nice option. And the low dose birth control pill allows you to have a very, very low amount of estrogen. So if you are using those and we use a really low dose, we can use pills, we can use transdermal patches, and we can use, again, a combination of estrogen and progesterone in a vaginal ring. Now we'll move on to progesterone-only options. And this is attractive because, as you all know, endometriosis grows and gets active in the presence of estrogen. So by using a progesterone-only approach, this is an ideal way of being able to decrease the amount of endometriosis and therefore the amount of pain. The problem is that many of the progesterone-only options carry with it some side effects. So what can you do? Well, if you're using a progesterone-only pill, there are now some progesterone-only pills that are less likely to cause side effects such as weight gain, bloating, or moodiness. There's a new pill out now that is just with drospirenone, and that can be better tolerated. So that's one option. Another option is the intramuscular approach with a depot progesterone. And that is usually really well tolerated and does well for endometriosis, but often has those miserable side effects of moodiness, wanting to eat all the time. So one of the things that I've done to sort of curb that is to add back the tiniest amount of hormone therapy, just a little bit of estrogen, as though the individual were postmenopausal. So the tiniest little patch or something like that. And that can really help take away some of those negative effects. And the other option is to insert a progesterone-only IUD. And a lot of people do very well with this in terms of their endometriosis, as well as not having systemic side effects. So that's a way of getting progesterone only without having to take anything by mouth or intramuscularly. We used to use a medication, danazol, which is very much like a testosterone, had some side effects such as hair growth, deepened voice. So we're not using that as much anymore because it increases testosterone levels. And then we come to the agents that you were talking about, the gonadotropin releasing hormone, either what we call agonists or antagonists, meaning acting like this continuous release that comes from the pituitary gland, or something that means the opposite of it. And both of these agents, whether they're given as a injection or a nasal spray or a tablet, both the antagonists and the agonists, what they do is they send the message to the ovary to say, stop working. Let's put you back into prepubertal levels, and estrogen levels plummet. They go way, way, way down, which is great for treating endometriosis. The downside is that you get all the same symptoms often that people get when they become postmenopausal. So many individuals will have hot flushes, they'll have moodiness, they'll have trouble remembering words, particularly nouns. The hot flushes are probably the biggest side effect that I see from using these medications. Some people get headaches, trouble sleeping. These can all occur because the estrogen levels are at their absolute minimum. So one of the things that I like to try in individuals that are taking these medications is to then add back a teeny bit of both estrogen and progesterone. And we don't want to use estrogen alone in this case because that will activate the endometriosis. So we use a combination. We do a combination of estrogen combined with progesterone. And then what else can we do? The aromatase inhibitors, that's next. So that is really used for people that we really want to get rid of all of the estrogen. None of the other agents that we've tried have worked. And aromatase inhibitors are used in, the indication for aromatase inhibitors is to be used for people who have breast cancer or estrogen receptor positive tumors, and we want to reduce the amount of estrogen. And the way it works is in our bodies, testosterone is converted into estrogen by aromatase. And so by blocking that aromatase, what ends up happening is we lower the amount of estradiol, which is great, except same symptoms. And so then we're left with the same situation. In this situation, we don't want to add back estrogen because we've just done all of this to try to combat it. So what we often do is add back in some progesterone. And usually we'll try to use one of the least likely ways of having any activation of the mood changes. So that kind of takes care of the different options. And it really, is, I like to say that in all of this, just like in anything in medicine, it's individual, because what's right for one person is not necessarily right for another person. So I really like to individualize and work with people to try to figure out what's best for them.
Right. So I have a few questions going back to combined oral contraceptive. My go-to hormonal treatment is IUD, progesterone, of course. Mm-hmm. Then continuous contraceptive pill continuously, because that way the patient doesn't have like a menstrual cramping and those menstrual symptoms during period. So what do you feel about that?
that is, I love that too. I really like, so the progesterone IUDs are terrific for a number of reasons. One is the local decrease in endometriosis that you get with the progesterone IUD, because the progesterone is being secreted continuously, which I really like. The other benefit of that is if we do want to add back just a teeny bit of estrogen, we don't have to worry about the lining of the uterus, because the progesterone IUD is going to be balancing it and keeping it all nice and quiet. And I love the low dose birth control pills as well, because if you give them continuously, hopefully there's no proliferation. We're just keeping a continuous dose, without stopping with placebos. We just keep going on the lowest amount that we can possibly do. I even have some people who I have doing both. I don't know if you use that, but sometimes I have people who have a progesterone containing IUD, and then in addition, they have a very, very low dose birth control pill.
Right. The other question is, so there is a few patients who doesn't like any hormone. Like that is what was the form of the hormone, side effect or any kind of problem. Like in which point, in which side effect symptom do you say no hormone? The patient cannot use the hormone. In which point do you decide that?
Well, I mean, one is patient choice, right? I think that if an individual doesn't want to try any hormonal option, then that's okay. And there are some people where, any kind of hormonal treatment is contraindicated. So for instance, in a patient that has an existing estrogen receptor positive tumor, like a breast cancer that is continuing to grow and is estrogen receptor positive, in that individual, we wouldn't want to give them any type of estrogen. We would be hesitant to try any combination oral contraception or vaginal or transdermal. So that would be a person that we would be hesitant to give that type of hormonal treatment. Someone that has a pre-existing clotting disorder, because the combined oral contraceptive does increase blood clotting. So someone that's had a previous pulmonary embolus or a deep vein thrombosis, or has a gene that increases their risk of having a blood clot, those are people that I would think of another avenue or another option. Even the non-steroidal anti-inflammatories can sometimes help. We're using some immunotherapy, looking at other agents that may be beneficial for in people who cannot take combined continuous hormone treatment.
Correct. Thank you. Thank you for the excellent answer. Moving on the next topic, I really want to discuss about hormonal treatment, somebody who has history of endometriosis, because unfortunately there's a patient who undergone surgery due to this, including hysterectomy or taking out the both ovary in a young age, in which case we definitely need hormonal treatment to support their bone and cardiovascular brain. So for example, if somebody who's gone to spontaneous menopause and has an extensive endometriosis history, and that's number one scenario. Number two, somebody who's a surgical menopause, like taking out the both ovary before menopause and has a history of endometriosis, and somebody who's young age, who unfortunately taking out the ovary, taking out the uterus, and then with the ovary has a history of endometriosis. Then I just really want to know your expert opinion in terms of hormonal treatment.
Well, these are all great scenarios, and it really emphasizes the point that no two people are the same, and how these are all different scenarios, and each one requires a different personalized approach. That being said, there are some general things that we can talk about. First of all, one of the benefits of, there are many, many, many benefits of estrogen. Estrogen is, we have estrogen receptors just about everywhere in our body. Of course, you know, but for those that are listening. And when there's no estrogen, many symptoms can occur. The ones we already talked about: hot flushes, moodiness, difficulty remembering things, trouble sleeping, dry vagina, all of these things can happen. In addition, what you mentioned is the long-term sequelae,
Right.
bone loss, because estrogen is really important for maintaining bones and also brain and brain health. So someone having surgical treatment of endometriosis and removing their ovaries at a very young age is at risk for developing, one, these symptoms, but two, long-term bone loss. And so that's an individual that in general, I really like to give a teeny bit of add-back therapy with a little bit of estrogen, knowing that any estrogen that I give could potentially exacerbate any existing endometriosis. And therefore, what I like to do is a combination and give progesterone and estrogen and try to keep the estrogen as low as possible. And just to give an example of levels. So if a reproductive age individual preoperatively had their own ovaries working, their estrogen levels in a given month would range somewhere between 30 and 300. When we're adding back estrogen, we're keeping that estrogen level between about 32 and 45. We're not looking to make sky high levels. We're just trying to keep a little bit to keep the bones happy, to keep the brain happy, to keep the body happy. And with that, we give back a little bit of estrogen. So if they still have a uterus, then in that individual, then that's a great way to add in the progesterone IUD with a teeny, teeny, teeny bit of estrogen, usually in a patch, sometimes by mouth, sometimes even in a vaginal ring. And then in an individual that had their uterus taken out, but they still have their ovaries, that's someone that it traditionally, when they go through menopause, we wouldn't even give them progesterone. We would just give them estrogen. But because of the endometriosis, we're very careful. And so we add back a teeny bit of progesterone, and we do the combination of estrogen with progesterone to keep the, we're constantly trying to balance side effects, mood, happiness with endometriosis and pain. And so we're trying to knock out the pain and knock out the endometriosis with all the agents that lower estrogen, but then add back in just a little bit to keep all the other factors as healthy as possible.
Right. Thank you. Obviously, somebody who has a history of endometriosis, the concern is always cancer. When we give the progesterone, the endometriosis lesion outside the uterus may be turning to cancer. That's the main concern. But I agree with you. I agree that the very small amount of estrogen and plus progesterone help them to maintain the reproductive level of the hormone. The next scenario is somebody who has history of breast cancer or any kind of estrogenic sensitive cancer, has endometriosis history. What kind of hormonal treatment would you offer?
Yeah, so this is a really difficult situation, and there are different types of breast cancer. So in this case, we're really in a very similar situation to a person that's had breast cancer that doesn't have endometriosis, because what we're really asking is, what can we provide for that individual that's safe given the history of breast cancer? So first of all, breast cancer is very common, and there are different types of breast cancer. There are estrogen and progesterone receptor positive breast cancers, and there are estrogen receptor negative breast cancers. So in an estrogen receptor negative breast cancer, estrogen is okay, progesterone is okay if the receptors are negative. However, if the estrogen receptors, progesterone receptors are positive, then that's an individual that we really have to rely on our other methods that we've talked about, our surgical approach, our nonsteroidals, our immune modulators, because that's an individual where really the hormone therapy is not an advantage. That does make me think, though, of the patients that I've had who have had breast cancer, who have also had endometriosis. It reminds me of the fact that some people, most people that have no estrogen eventually will develop vaginal dryness. And vaginal dryness can be incredibly uncomfortable, itching, vaginal burning. People describe it as having sandpaper in the vagina. And this is something that we can treat. We can use a local estrogen that's administered just inside the vagina that can be able to help. And in most cases, because there really is no systemic level, that blood levels will remain extremely, extremely, extremely low, then in most cases, even patients that have endometriosis can take the vaginal estrogen. And in that case, we don't even need to add the progesterone component to that. So that's something that's really important. And I try to remember that in telling patients about it before it happens, so that they're ready and they're armed and ready to handle the vaginal dryness and have some options. There are over-the-counter products as well that can help. Hyaluronic acid is really helpful to be able to counterbalance the dryness that can occur with all of these low estrogen states.
Sounds great. And these days I've seen quite few population who's using bioidentical hormone.
Mm-hmm.
Somebody done multiple surgery for the endometriosis because they are so, they have
Mm-hmm.
this mindset that, the hormone is not good
Mm-hmm.
for their endo. So they
Mm-hmm.
go to some, they are using the bioidentical hormone.
Mm-hmm.
What do you feel about that? Do you have a
I really like to stick to FDA approved, regulated options.
right?
The bioidentical hormones that are potentially either by prescription or over the counter are not regulated. There's not a dose selection. There's no quality control, and they're not FDA controlled. So that concerns me. There are situations where I replace estrogen and progesterone as naturally as possible, meaning that I will rely on the patient's symptoms. I will try to use the lowest amount possible that allows for the treatment of the symptoms. And that sometimes requires getting a blood test and seeing where is the blood test, and then changing the dose. So in a way, we are using these FDA approved agents, but bioidentically. In other words, making them for the individual that we're treating. And it's real, how I see it is it's individualized care. That's what it really comes down to, not really bioidentical versus non-bioidentical or natural versus non-natural. It's really what is safe and effective and appropriate for each person.
So you never used that's not your first choice, correct?
I make bioidentical with FDA approved, quality controlled agents. I do it individually.
I see. Sounds great. We have let me see, we have 2 questions just arrived. There's a question, I cannot answer this question. Is bioidentical hormone therapy covered by insurance? Do you have any idea?
I don't have an answer for that. I don't know. My guess is probably not, but I since I don't prescribe it generally, I don't know.
Yes. And the second question is, Dr. Nachtigall, in the beginning, you mentioned about combined hormonal treatment with estrogen and progesterone for suppression of endometriosis. And there is a question regarding progesterone hormonal treatment can actually suppress the growth of endometriosis or help shrink the endometriosis tissue.
Well, that's, I think both are
yes,
possible.
Yeah. Possible. Yes.
So, and that's the goal. The goal of treatment is really to do both, to suppress the growth of endometriosis and to shrink what's already there. That's really our goal. And another one, which is prevent new areas of endometriosis.
Yes.
So that really is what we're trying to do.
The randomized study recently published that if they compare the control the hormonal treatment group after surgery in 5 years, if no hormonal treatment, 50% population has a recurrent endo. So that reflects how important of medical treatment even after the surgery.
That's a really good point. Is one thing we didn't mention is the combination. You know, very frequently we'll do, you know, you'll do surgery and then we'll do the medical management. Is that, although we like to work together, and that sometimes patients need both surgical treatment and then medical, or medical, surgical, medical, but combination, and really everything trying to have regression and suppression. And I think the word I used, suppression, was really talking about the ovary and suppressing the hormones that the ovary would otherwise be making, because by suppressing the hormones, that's going to allow for the shrinkage of the endometriosis and the prevention.
Yes. In different scenario, obviously it's a case by case, and we have to individualize the patient condition and severity of endo. But is there any specific endo condition you prefer, progesterone only or combined estrogen versus IUD? Is there any specific condition would you prefer certain hormonal treatment? Because they also study recently, I'm not sure it's a randomized study, but the study in European study shows that progesterone only pill is more preventable for like deep infiltrating endometriosis, the rectovaginal septum. You know, the European, they have the dinogesterone, different form of the progesterone, which we don't have in the state. So I'm just curious, in your perspective, is there anything you see certain hormonal treatment is good for certain disease?
Well, I think just as you said, once there's infiltrating, you know, I really like the IUDs. I think that that's really helpful. I'm wondering how, you know, what you feel as well. And I also think that sometimes, although frustrating, there may be a degree of trial and error, is that we often try one first, and then if it's not working, we move to a different one, again, because what works for one person may not work for another. But and that we can make them additive. Just you know, we can use the gonadotropin releasing hormone analogs and antagonists, and then on top of that, we can use a teeny bit of add back, and the add back would be in similar doses to hormone therapy. Or we can use a progesterone IUD, and then in addition, you know, use gonadotropin releasing hormone. So, you know, I think not limiting ourselves to one treatment for each individual is sometimes what we have to do in order to decrease pain and progression. Sure.
But my next topic is about testosterone, because most for endo patient who's going to menopause, obviously they're afraid of taking the hormone, and they complain that decreased libido, low drive. And do you ever use testosterone for this population?
So that is such a good question. So testosterone is not FDA approved for the use in women. However, and it's not FDA approved for supplementing in patients that have no testosterone because their ovaries have been suppressed. Because there are two places in the body where estrogen is, where testosterone is made. It's made in the adrenal glands and it's made in the ovaries. So if we are purposely either removing the ovaries or medically making the ovaries non-productive, we're setting these people up for hypotestosterone states. And that can definitely cause symptoms such as low libido, sometimes also lack of energy. So the answer is it's not FDA approved. However, I have off-label given these individuals low doses of testosterone supplements in either a lozenger that they can put under their tongue or in a cream that you can put on the skin so that they can bring back low levels of testosterone, not sky high. And I almost always measure the testosterone level to make sure that I'm not creating a hyper testosterone state, a hyperandrogenic state, because that would cause, you know, other side effects such as acne or hair growth. So we really want to, you know, keep it. But yes, I have to admit that I have done that.
I see. We have a question arrived just now.
So the question I see is when should a patient decide on hormonal treatment versus seeking surgical treatment? And I think this is where I would say both. In other words, because surgery is surgery and there's always a risk of a complication in surgery, I tend to start with medical treatment and then move to a possible surgical option. However, I don't think it's a bad idea to get an opinion from both sides and investigate what would be right for, you know, you as an individual. What do you think?
I agree with you. First of all, good physical exam and thorough like history taking, and obviously patient symptom, and open. I use the MRI, pelvic MRI.
Yes.
So
very helpful.
Yes, and then also very importantly, whether patient desire to have a children urgently.
Yes.
Yes, that's very, so based on all the things together, you know, the surgery or not, and, you know, obviously the surgery has risk, and there is an increased risk of decreasing ovarian reserve, and also risk of anesthesia and risk of surgical morbidity. So I think the communication with the patient is most important. That's the key. And then based upon those decision making, I will proceed either medical treatment or surgery. I agree with you, but most of the patient who doesn't want to have a baby right after surgery, I put them hormonal suppression treatment.
And one of the nice things about all of the methods of hormonal treatment that we have talked about is that they are reversible. That if you're on a combined, continuous, really low dose pill and you want to go off, you go off. You're back where you were before. Progesterone, you stop it. An IUD, you take it out. Even the gonadotropin releasing hormone analogs and antagonists, they're reversible. You stop taking it and your own cycles resume. So they're all reversible options. Whereas once you've had surgery, you've had surgery. So I think, you know, that's just something to think about, that it's nice to try something that you can get rid of if you want to.
Right.
But I love what you said about the about the history, because so often I learn so much just about the history, you know, talking to patients and finding out what have they been through so far, where is their pain, how is their pain, what is it, what exacerbates it, etc. So I think that that this is really, really important. And what are their goals? Because that's so important.
Right. Great. I think that's about it. And then I'm looking for any question. Is there any questions? Do you have any comment? I think we cover all, right?
I mean, I think that, you know, one of the things about endometriosis is just that it is, as you said, it's chronic, but that it's so varied in its presentation and very common. And so I think that it's great that there are so many options now, and how important it is to talk to your trusted healthcare provider that's taking care of you, to, someone that's familiar with endometriosis to be able to help guide you. I think one of the things that I have seen in patients that are coming to me is that it's often taken them a long time to get the diagnosis. And that can be extremely frustrating for individuals. So I think that one of the things that I would say is that if you're experiencing, pain, etc., to seek attention and to investigate and to not be afraid to try some of these hormonal options if you don't have a contraindication to it. And like everything, I think listening to my patients is critical, and individualizing the options. I think that is absolutely essential.
Wonderful. Wonderful. I think that's it.
Okay.
It was great talk, and then I really enjoyed the webinar.
Thank you so much for having me. I really loved being here with you. Thank you.
Yeah. Thank you.
Okay.
Bye.
Bye.
Bye.